pathogenic causes. It could be broadly classified into craniosynostosis, premature closure of sutures, which either syndromatic like Apert or Crouzon syndrome, and non-syndromatic. Also, there is anomalies of the first and second pharyngeal arches, example, hemifacial microsomia and Treacher Collins syndrome. And lastly, orofacial clifts. It needs teamwork and management, including thorough history taking, genetic evaluation, full clinical examination, radiological examination, surgical procedures, and rehabilitation. So what we are concerned about is the imaging diagnosis. It includes plain radiography, computed tomography, multi-detector, which is the gold standard, and MRI, which is complementary in the evaluation of associated intracranial lesions. So with the appearance of multi-slice CT, new era has come in imaging of craniofacial deformities. It rapids, needs only sedation, and with thin cuts reaching maybe ½ millimeter, we could reach to the isotropic voxel with excellent multi-planar capability, 3D volume and surface shaded and MIP images. So I'm going to show you a group of cases for the various deformities we could meet in our practice. This is the first case. We are going to start with craniosynostosis. A 6-month-old boy with a deformity in form of increased anteroposterior diameter of the skull. Whenever we are suspecting craniosynostosis, we do the free plain X-ray views, the standard views, which is sagittal, Townes view, and occipitofrontal. To understand where is the pathology, we have to look to the normal first. The normal, in the normal, we could identify the sutures adequately here, the lambdoid, the sagittal, and the coronal sutures. We don't find, in this case, the sagittal suture. There is synostosis of the sagittal suture. To make more confirmed, we do the CT with the volume rendered image. We could see adequately here that the sagittal suture is synostosed, and in the coronal view, we could see the bone deposition at the site of the synostosed suture. So this is actually, and we have the dolichocephaly, the increased anteroposterior diameter of the skull, evident in the axial and in the sagittal scans. So this is what we call non-syndromatic sagittal synostosis, dolichocephaly, what we call dolichocephaly. So another case of craniosynostosis, here we have pointed skull, adequately seen here. There is pointing of the skull. And at the site of the skull, as we could see here, this is the synostosed metopic suture. So this is the site of the metopic suture with frontal bony ridging. The other sutures are patent, and there is pointing and abnormal deformity of the skull. This is non-syndromatic metopic synostosis. Another type of craniosynostosis, which is actually unilateral craniosynostosis. We have the coronal suture fused, and we have the lambdoid suture at the same site also fused. This is what and this led to what we call oblique skull deformity. This is plagiocephaly. What do you mean by plagiocephaly? Is that this is the oblique skull due to synostosis at one side only. Another case of craniosynostosis also plagiocephaly, but this is frontal only. The coronal suture is the one synostosed on one side, while the other sutures are patent. There is a very nice sign here. Here, the right ear is here, and the left ear is anterior to the right ear. This is a sign, and there is flattening of the skull. So whenever we have the two ears not on the same size, not on the same level, this indicates that this is due to craniosynostosis. Why I'm showing this? Because sometimes there is abnormality or plagiocephaly with flattening of the skull. Like we see here, left occipital plagiocephaly. But as we could see here, the two ears are on the same level. The two ears are on the same level. If I do the Towns view or I do the volume rendered, the sutures are patent. So this is a positional plagiocephaly. It occurs because the baby lies on the same side for a long time while he's still very young. This leads to the deformity, which is positional. This is not related to craniosynostosis. So let's shift to the syndromes of craniosynostosis. Here, what we have here is synostosis of the two coronal sutures. Whenever I have bilateral coronal synostosis, I have to suspect that this is syndromatic. What are the other anomalies in this syndrome? We have oxycephalic configuration of the skull, elongation of the skull because of the coronal synostosis. We have shallow orbital cavities and bilateral proptosis. We obtuse angle of the lateral orbital angles, what we call frontalization of the sphenoid bones, and we have mid-face hypoplasia. Also, in the MR, there is ventriculomegaly, and there is syndactyly of the feet and hands and fingers and toes, as you could see, soft tissue syndactyly, not bony syndactyly. This is actually what I call Apert syndrome. Another syndrome, also bilateral coronal synostosis, proptosis of the globes, and shallow orbits and mid-face hypoplasia. This is also an indication of what we call Crouzon syndrome. The main differentiation between the two syndromes, Apert and Crouzon, is that in Crouzon there is no syndactyly of the fingers and toes like Apert syndrome. So this is what we call syndromatic synostosis Crouzon syndrome. So non-syndromatic craniosynostosis occurs 1 per 1,700 live births. 85 of craniosynostosis are non-syndromatic, including sagittal synostosis, coronal, and metopic. 75% of bilateral coronal synostosis are syndromatic. So when to suspect syndromes? If the bilateral coronal synostosis. Planar radiography is actually accurate in 89%. CT is 94% accurate. It determines the extent of synostosis, effect of the brain, and post-operative follow-up as well. This is a nice diagram showing the different types of craniosynostosis. So this is the normal skull. When there is synostosis in the sagittal suture, there is elongation of anteroposterior diameter, which leads to when there is synostosis of the metopic suture, there is trigonocephaly and pointed skull. When there is synostosis of one side, it is called plagiocephaly. When there is synostosis of the sagittal suture, there is elongation of the skull, what we call scaphocephaly. When there is synostosis of the coronal sutures, there is brachycephaly or oxycephaly because the skull grows in the side-to-side image. And of course, as I said, sometimes the plagiocephaly is not due to synostosis, it's only deformational without synostosis. So the syndromatic craniosynostosis includes more than 90 syndromes, including Crouzon and Apert. Other syndromes includes Pfeiffer and Carpenter. It includes bilateral coronal synostosis, mid-face hypoplasia, shallow orbits, and exotropism. Syndactyly of fingers and toes occurs only in Apert. Other associated anomalies in syndromes of craniosynostosis include skull-based deformities. We have small skull base, ventriculomegaly, corpus callosum anomalies, parahippocampal and gyral abnormalities, and optic nerve atrophy. So this is a nice case for another type of deformity. Here what we see here, a very large facial cleft extending through the maxilla, palate, nasal bone, ethmoid, and extending to the frontal bone. And it is well seen here in the coronal, involving all the nasal bone up to the frontal bone. When we did an MRI, there is associated agenesis of corpus callosum, and there is a large interhemispheric lipoma. What we also realized that there is hypertularism. The distance between the two orbits is very large. And there is also like a small meningocele or small herniation of brain tissue through the defect. This is what we call frontonasal dysplasia. So what I want to show here is that we have hypertularism. The distance between the two orbits is large. Another case of facial cleft, premaxillary cleft, the distance between the two orbits is small. There is hypotolerism. Whenever I find decreased distance between the two orbits with a facial cleft, I have to suspect that I will detect holoprosencephaly in the brain. In opposite to, if I have hypertolerism, there are anomalies of the corpus callosum. So when I did an MRI, there is semilobar holoprosencephaly with fused salivae, frontal lobes, and there is partial single monoventricles with partial development of the temporal and dorsal horns. So this is facial cleft, premaxillary cleft with semilobar holoprosencephaly. Orofacial clefts involve osseous and soft tissues, wide variation and extent and location. Cleft lip, of course, with or without palate, represents the majority of facial clefts. Whenever there is hypertolerism, search for corpus callosum anomalies. Whenever there is hypotolerism, search for holoprosencephaly. Let's shift to the third type of anomalies, which is the first and second pharyngeal arch anomalies. This is a nice case. The child is coming with prominence on the face on one side and small size of the face on the other side. Well seen here in the volume rendered and technique. If we do see the CT coronal, here we find the masseter, temporalis, and pterygoid muscles are large, while they are small on the other side. Also, we find that the mandible is large here, while this side, the ramus of mandible is small. So what we have is hemifacial microsomia, or atrophy on one side. Associated anomaly is atresia of the left external auditory canal. With these type of anomalies, we have to search to associated ear anomalies. So this is what we call hemifacial microsomia. It is the second common facial birth defect after cleft lip and palate. 1 to 5,600 live births, affects bones and soft tissue, and high associated with ear anomalies. Another nice anomaly, here on the opposite, there is hypertrophy of the soft tissue of the face on one side. The bone is nearly the same, but the hypertrophy is in this soft tissues and muscles on one side of the face and cheek. No associated masses, no associated vascular malformation. It is just hemifacial hypertrophy. Of course, before doing the MRI, we could suspect there is neurofibromatosis, there is vascular malformation, but when we did the MRI, we found only hypertrophy of the soft tissues. Another nice case, what is the abnormality here? There is an abnormality which, if we do see and realize, there is no zygomatic arch nor zygoma in both sides of the face. And there is also acute or obtuse mandibular angle with receding of the mandible. This is what we call Treacher Collins syndrome. Treacher Collins syndrome, there is no zygoma or zygomatic arch and small hypoplastic mid-face, and as we see, obtuse mandibular angle. Here, the orbit is informed, lateral wall of the orbit is entirely formed by this sphenoid bone only, no zygoma. This is what we call Treacher Collins syndrome. What we call mandibulofacial dysostosis. It is autosomal dominant, and the main diagnosis is by hypoplasia or deficiency of the zygoma. We have mandibular retrognathia and obtuse mandibular angle and hypoplastic maxilla, and always search for associated anomalies of the temporal bone. Another case, nice case in which there is hypoplasia of the right side of the mandible and the mandibular ramus. The TMJ is not present, or the condyles, mandibular condyle is not well formed. And as we see, there is atresia of external auditory canal on one side. So always with these types of anomalies of the face and mandible, search for anomalies of the ear. Mandibular hypoplasia. Last case, there is the ear pinna is well formed here, the ear structures. Here we don't have an ear pinna. There is no ear pinna, and there is no external auditory canal, and even the middle ear cavity is small and shows opacified with this plastic appearance of the ossicles, which are displaced to the lateral wall of the bony lateral wall. This is actually what I call microtia or anotia. Here, as we see in the volume, the external auditory meatus is well seen here, while it's not seen on the other side. So this is what we call microtia or anotia. So CT, as a conclusion, multi-detector, is the first line of choice in imaging of craniofacial malformations using 3D and volumetric imaging. Complementary MRI should be done for cases with associated suspected intracranial lesions to confirm presence of ventromegaly, metricomegaly, chiari, anomalies of corpus callosum, and holoprosencephaly. Orientation of the different pathologies before interpretation helps you in writing your report and adequately detecting the lesions. Thanks a lot.
Thank you, Dr.